Good afternoon, everybody. You're very welcome to Dr Steevens Hospital to our weekly press briefing. I might just begin by asking the panel to introduce themselves. I might start with you, Ross, at the end.
Hi, Dr. Ross Morgan. I'm a respiratory physician in Beaumont Hospital.
Colm Henry, Chief Clinical Officer, HSE.
Anne O'Connor, Chief Operations Officer.
Paul Reid, CEO, HSE.
And I'm David Leach, Deputy Director of Communications with the HSE. And you're all very welcome. I'm joined by Michael and Margaret, our Irish Sign Language interpreters. And I might begin by asking Paul to address you.
Thanks, David. And good afternoon, everybody. And belated Happy New Year. There's no doubt that we're still in a very uncertain period in terms of the impacts of Omicron. And from a HSE perspective, we remain on kind of high alert in terms of the impacts, particularly that it's having on the healthcare system overall, not just our hospitals. And we are seeing literally persistent stress across the system overall, and particularly in the impacts of staff, which I'll bring you through very shortly. But as with everything else, I think I would just like to take a moment to just give some level of optimism across a range of areas that have helped. And first of all, just to say that the period of time that we have had to vaccinate particularly vulnerable people, I've no doubt has helped and will help us in the medium and longer term, particularly older people, particularly vulnerable people. And that time period has helped us. There's no doubt the government actions in terms of restrictions that have had to be put in place have certainly helped the health service. And related to that, the public actions in particular, and the way the public have taken on board those public health actions, particularly throughout a difficult period in Christmas and New Year, I think has been great and insightful by the public how they've embraced them. And there are strong indications, and early strong indications, that the level of sickness may not be as severe, and probably not as severe as certainly as the Delta variant. But as you'll hear later on today, we do have Professor Ross Morgan, who's a clinical lead in the health service, and he is a respiratory consultant, and he'll give a kind of on-the-ground insight into what level of sickness we're experiencing. And the final level of optimism particularly relates to the ICU impacts. Haven't seen the severe impacts, certainly to date, as we would have seen an equivalent period last year with Delta hospitalisations. But again, I qualify all of that level of optimism that we have to balance that in the level of reality. And the level of reality is we still have and do have a healthcare system under extreme pressure. And very conscious, there's often comparisons made between this time now, January 2021, versus January of last year, 2020. And just to provide a level of context around some of those comparisons, because yes, certainly in January of 2021, we had over about 2,020 people in hospital and about 220 people in ICU. But at that time, it's important to mention, all other healthcare services were suspended, not just from a hospital perspective, but specifically from a community perspective as well. The country was in a complete lockdown. There was practically no traffic on the road. Economy and society was completely wound down and wound back. We're in a very different perspective now with the economy primarily fully open and society much more open than it was at that time. And certainly we didn't have the thousands of resources that we currently have dedicated to testing and tracing to the level that we did have last year. And we didn't have thousands of resources focused on a vaccination programme. So the draw on our health system overall is very significant compared to what it was this time last year. And do layer into that, which is being specifically and very harsh and very hard on us, the staff impacts due to COVID sickness and indeed public health measures related to COVID and staff. And just to give you a little perspective on that, we have been calculating the impacts on staff and manually getting the census from the services in terms of what's the current position with staff who are out sick with COVID or isolating or generally with public health measures overall. We do have our returns as of today, and I want to qualify the returns. The returns do set out that there's at least 8,500 people, staff now, that we have got a return on, a manual return on. However, I would certainly qualify that figure to say that our sense of it is, firstly, that is looking back a week, and we do know the acceleration we saw in the period of that week. To give examples, some healthcare settings went from 60 people out, staff out, to over 300 people out during the course of this week. Some people had a very low level of staff out and all of a sudden had 300 people out in our community services, just to give a couple of examples. So our judgment on it is that we could be at least 12.5% impact on staffing levels, and it could be even double the number that we're reporting on today. But the manual count of numbers that we have is 8,500. And just give you a scale on that, even within that range of numbers, even within that 3,500 to 8,500, you are looking at over 3,000 nurses and midwives, over 1,500 staff who will be involved in patient and client care, almost 1,500 health and social care professionals. So this is real frontline impact on us overall. And you'll have heard in media reporting various hospitals saying they have up to 14, 15% of staff out overall. So this has been a very significant impact. What's been particularly impactful has been the pace and force of it, as I just gave you a scale, how it happens so quickly and so impactful. We would have, of course, hope that we begin to see many of people coming back from the various isolation periods, but equally, we still haven't seen the tap turned off in terms of staff being impacted. Just in terms of looking back at January last year, again, just to put on scale a few points that might help put context and things also where we are. This week last year, if you look back, we were reporting here today that we would have by the end of the week 35,000 vaccines administered, completed by the end of this week. Today, as we stand here today, as you'll know, we've almost 9.8 million vaccines administered. And if you take 4-day period alone prior to Christmas, almost 420,000 vaccines administered. If you look back at the equivalent week last year from a testing, resourcing or training perspective, over 100,000 PCR labs completed. This week we'll have completed up to 300,000 PCR, along with an additional approximately 350,000 antigen tests distributed. This time last year, we were running at severe positivity levels, growing at around 20%. This time, as you know, we're well over 50% in terms of positivity levels overall. So, and similarly, this time last year, just to give a little bit of context of how we've advanced, we were just starting, we had just kicked off our COVAX system for the registration of vaccines, which was a very manual system. We're now running on the 18th release of the COVAX system to accommodate all the various changes, etc. So I do think there are some positives that we can stand back and take from the pandemic workforce capacity and capability that we have put in place over the course of the year. And while it is very challenging, it is important just to reflect on some of these. We do have overall enhanced capacity and dedicated workforce from all aspects of it, and that's public health, our testing and tracing, resourcing, and indeed our vaccination. And I'm not specifically referencing the healthcare system overall, which has been enhanced by about 11,500 since January 2020. We do have a much more, in my view, aligned health system in terms of how the HSE, working with GPs and indeed working with pharmacies in a much more coordinated and focused way, not just on vaccines, but also throughout the winter period. And each wave and this pandemic so far, we all know every wave is different. And this one, particularly, we can hear some clinical aspects of it, but also from a staff impact, much more severe. And I do think the public have a much stronger, greater awareness in terms of the public health responses needed at the right times, and they've reacted many times ahead of the public health advice, and I do also want to thank them again for that. And we also have a workforce which I'm hugely proud of throughout all the waves so far, and now have served us no matter what impacts they have had to experience, just galvanise around every time and I think great credit is due to those. And most importantly, also to reference the vaccination programme that we have, recognised as one of the best in class in the world, but more importantly, the benefits that it's providing to us. Notwithstanding some of the impacts we're receiving today, if we didn't have the level of uptake on our vaccination programme, we know we would be in a much worse position. And indeed, I know Ross later on will give some insights into what he is seeing from a clinical perspective of vaccinated or not vaccinated. And so just very summary terms, you will have seen earlier on the note that I issued out to the system earlier on this week in collaboration with some of my key executive colleagues. And that was setting out basically the impacts and some of the actions that we have to take and some of the priorities. And the priorities were very simply that we'd focus on urgent and time-dependent care. We'd focus on the impacts of COVID and that it's having across the system. We would sustain to the level of possible our resourcing and testing and tracing, and also on vaccinations because they are key in terms of getting us out of this. However, other key community services are being protected to the extent we can, but they too are being significantly and severely impacted based on the staff impacts we've seen. Very briefly again, Colm and indeed Professor Morgan will go through some of this, but just from what the services are feeding back to us about what they're experiencing. We mentioned earlier on some worldwide evidence and some evidence from our own around the severity of the illness. What we are seeing on a national level is the length of stay is remaining probably around the same as what it was. So still needing that level of treatment. And I always qualify this because a lot of commentary is about maybe the sickness may not be severe. Nobody wants to end up in hospital. And if you end up in hospital, you're in hospital because you're sick and you need a high level of acuity treatment. So I think we always need to remind ourselves and remind everybody, hopefully not as severe, but nobody wants to end up in hospital. And what has been impactful is the sheer volume that came at us so quickly, and particularly the transmissibility of it, extremely hard to protect healthcare systems in such high transmission levels. So we've very simply 5 key areas we've been focusing on: increasing our capacity in testing and tracing, along with the increased use of antigens, acceleration of the booster programme now across all ages and indeed younger children, continuation collaboration with the GPs and pharmacy overall, general practice and pharmacy, prioritisation of the healthcare system throughout this period, as I mentioned earlier on, and continued public communications in terms of where we're at. Very briefly, just on hospitals and ICU, we're now at, as you know, from today, 941 COVID positive patients in hospital, which is up 65% on the same day last week, and indeed up 140% on 14 days ago. The number of COVID in critical care as of this afternoon is at 94. As we've said, remaining generally stable, and which Ross may touch on later on, and I've always given you the updated figures. 51% of our patients in ICU today have had no vaccination at all, and a further 3% have been partially vaccinated. And I will make the call that I will say every week, we are still there, we're still working through groups who have, and we're still seeing some people getting their first and second doses. We don't have our colleague Damien McCallion here today, so I just wanted to summarise very briefly some of the information on testing and tracing. I won't read through it all, but you will see in terms of the rising levels, and particularly if you see the second bullet point there in terms of the community positivity level now over 60%. The lab tests 282,000, but that will be up to 300,000 when we see the 7-day rolling average after today. Increased use of antigens, and you'll see the various areas that we just outlined here and where they are, and scaling up testing capacity overall. And we are seeing the demands come at us significantly strong in terms of demands for antigen. So 299,000 kits distributed are booked for asymptomatic close contacts. And indeed, as we're seeing this week alone, almost 100,000 tests distributed for symptomatic 4 to 49-year-olds. I should say in terms of antigen tests, and you know this, but this is not an infinite supply, it's not elastic, so we would urge the public to seek those for the appropriate scenarios that set out with 4 to 39, etc., and symptomatic. Very briefly, just to reference the scale up of our total capacity, which is now, as I've said, 300,000 PCR and indeed 350,000 of antigen. And you can see the scale up, and Damien would have presented this previously over the previous course of the previous year. And that's very simply our dashboard in terms of the total lab tests and equally swabs taken in the community. Just want to briefly touch on the vaccinations update, and we are, as we've shown previously now, 94.5% of the adult population have received their dose 1 and dose 2, and very positively, still people coming through for dose 1 and dose 2. And you see 3,000 dose 1s last week and a further 6,000 dose 2 uptakes. We have launched the children. Happy to answer some questions on that later on. It's actually it's closer to 70,000 right now as we're here speaking to you, and it's about 6,500 completed to date. This is a slower process in terms of vaccination of 5 to 11-year-old kids. The process in the centres is much slower. It's at least double the time frame, and so it should be to bring kids through in the proper manner. The booster figures that you'll see there, total almost 2.28 million at the moment, booster additional doses completed, and 62% of the eligible population. And just making the point again, which is proving very successful about booking your own appointments, proving very popular overall, and giving people flexibility for their own appointments. Just on the uptake across the ages there, you'll see the summary of it and continued uptake. And this is the proportionate uptake for those who have already received their dose 1s and dose 2s. Important to reference, the other factor here is that in terms of percentage uptake, what we have to factor out are those who will have tested positive in the past 3 months. So that is, and particularly with the volume we've seen over the last couple of weeks or so. But we are seeing steady and continuous progress. Just a urge to the public, again, to please come forward for your vaccination, and we've all the resources there to do it. Still performing quite strong from an EU perspective overall on boosters programme. From the adult population, 18 years and over, Ireland ranked second overall, and then in the total population overall, you'll see and the booster programme, you'll see we're now ranked third. And to close on this one, if you do have, and make this real strong plea again to everybody in terms of coming forward for vaccinations and boosters, and you'll hear from the clinics here today how important it is. But there's the criteria for coming forward and the ways in which you can come forward, booking your appointment online for the vaccination centres. A number of centres continue to operate walk-in clinics, and just look at our site and you'll see the details of those. Contacting your local pharmacy, participating pharmacy, and you can see the list on our site overall. And then equally the GP will contact you for an appointment. Please don't contact your GP. And dose 1s and dose 2s will continue. So closing messages from myself are, first of all, to restate what I just said here. We really want to see people coming forward and continue to come forward in the strong numbers that they did prior to Christmas. Secondly, our services overall are under relentless pressure, and I'd ask people to understand that, be kind again to our staff, whether it's in the swabbing centre, whether it's in any of our healthcare centres, they are under significant duress. And our hope overall is that sometime in January, or sometime certainly soon in the coming weeks, that we're all looking back on the impacts of Omicron and know that the actions we have taken have been the right ones. But right now, we're still in the middle of it. Thank you. And I'm going to pass it across to my colleague, Anne O'Connor.
Hi, everyone. We'll talk through the services and where we're fixed now. I suppose, again, it is still, the 6th of January, so we're very much in our early New Year phase where our services would be fairly busy anyway, regardless of COVID. But just in terms of where we're at, unusually in the past week, we've seen a significant increase. So we would normally see this around now. But the increase last week up to Sunday was up 8.2% on the previous week. And you'll see there in the graph that that's a different direction for that line to be going that week. So up 8.2% to 23,507, which is nearly 26% more on the same week last year, down 3.1% on 2019. Now, again, we need to remind ourselves that in 2019, at this time, we were in the throes of a really serious flu season, and we had many older people being presented to hospital and being admitted. So any difference here really relates to the fact that we don't have flu. But as you can see, our emergency department's extremely busy over the past week. And as I said, this data is up until Sunday gone by. In terms of our admissions, just up 1.5%, which is 17.3% on the same week last year and 3.4% down on 2019. Where we've seen less activity in terms of the 2019 is the 8.9% there for over 75. So although we're up 1.9% on last week for people aged over 75 and significantly up on last year, that's down on 2019. And again, we would relate that primarily to the absence of flu this year. But again, a significant number, 3,289 presenting aged over 75 last week. And in terms of admissions, down 1.3% on the previous week, up 16% on last year, but down 12.6% on 2019. So still very busy across our whole unscheduled care system. In terms of our patient experience time, we can see that that's pretty similar. So in terms of last week, just down 0.3% and only down 1% on the same week last year and up 0.5%. So that is remaining, I suppose, at that kind of 97%, thankfully. And that's obviously a key metric for us. The 9-hour patient experience time for people aged over 75 has gone down 7.8% on the previous week, which is down 18.7%, but a 0.7% improvement on 2019. So again, we know that in terms of our performance around our patient experience times, that's very much related to the capacity within our system, so the availability of beds, etc. In terms of our weekly trolley count, again, that's gone up significantly on last week, which would be expected. So coming up to Christmas, we generally have more capacity in our system. People are discharged just before Christmas, which creates bed capacity and allows, I suppose, for a reduction in general in trolley counts, which is only really a symptom of patient flow within our acute hospitals. That's up on the same week last year and down 50.8% on the same week in 2019. So again, we have very busy sites. We are under pressure in many sites now in terms of unscheduled care, and we are seeing that in terms of trolleys. So this morning we had 249 patients on trolleys at 8 o'clock, which is up significantly 165% on the same day in 2020, but lower than the same day. Actually, that's wrong. That should be 2021 and 2020. In the past 7 days, we've seen the number going up. So in terms of, an increase in terms of the average numbers of trolleys, again, increasing there. So we are seeing congestion within a number of our sites. And particularly over the past week, we've seen that on our Model 3 sites. We are very dependent on our Model 3 sites. So we're talking about Letterkenny, Portlaoise, Mullingar, Kilkenny. So sites that have been under pressure in the past week in terms of just not having as much bed capacity available to them compared to some of our big Model 4s. However, we are also now seeing pressures in a number of our big Model 4 hospitals. And I'll come to the staffing challenge there in a minute. In terms of our delayed transfers of care, again, this is a very important metric that we present every week in terms of people who are delayed in hospital who are medically fit to be somewhere else. So they could either be, for example, at home with additional supports in a nursing home, or in some cases they are awaiting access to a specialist facility, so for example, a national rehab hospital, etc. Now we've maintained that, so it's up slightly on the previous week and up on 2020 by 27.8%. But again, that number at 496 is lower than it would have been in 2019 and significantly lower than it would have been in any years previously. So we have maintained that number below the 500, which is still a lot of people in hospital. But in terms of bed days lost last year, we had over 27,000 bed days lost compared to 55,000 bed days lost in 2019. Just in terms of the sites today experiencing pressure, we can see that Mayo, Portiuncula, Cork, Mullingar, Vincent's and Limerick are all very busy. And again, higher attendances. What's really important here is that in terms of presentations to a site, for us, it's kind of a three-legged stool in terms of our unscheduled care presentations, so people coming through the doors of our emergency departments, along with people who are admitted in our hospitals with COVID, along with then any other work that we need to do in terms of scheduled work. And obviously this time of year, we wouldn't be doing very much of that. So most sites do not book many people in this first week in January, regardless of COVID or any other reason. But that post-Christmas, post-New Year surge is a predictable surge for us. Once people go back to work, or certainly once the GPs get back into normal business, people will present to their GPs and be referred in, and we always see a significant surge in activity in that first week in January. Just in terms of the impact on the health services, and Paul referenced the staffing situation, we know, as Paul said, that the numbers, so whilst we have a formal HR report We also know ourselves from sites that sites are all working on a basis of an average of about 12% of absenteeism. Now, what that translates to, depending on what number you want to count, we know that if you're looking at possibly around 120,000, 130,000 working in the health and social care services, or even more than that, we're looking at between 14 and 15,000 or 15,500 people within that number. And they are people who are COVID positive, but critically that higher number also reflects people who are at home, who aren't sick, and who can't come into their workplace. Some of those people can work from home, but in fact many can't. So for example, if you're an ICU nurse or a paramedic, there's not really a lot for you to be doing working from home, whereas there are other people who may be able to do more. So at the minute, we are working off an average of 12% across sites. That is not uniform. Some sites are reporting about 20%, others are reporting a smaller number. If you look today, for example, at our National Ambulance Service, we have 260 people who are unavailable for work. Again, that's a very significant number at a very busy time of year. We are working with all of the sites in terms of the challenges that this presents across the board. And just in front of you there, you'll see the range of challenges across our health system. So inevitably, we see bed closures, and we have bed closures. We have some sites, for example, in Galway, where there are a significant number of beds closed. That is what will happen if we don't have enough staff within a hospital. We have some beds closed for infection prevention and control reasons, but we now have a significant number of beds closed as a result of staffing challenges. We have increased waiting lists. I'll come to those in a minute. Our impact on home support. And again, we have to remember that these staffing challenges are for the whole health and social care system. So it's not just within our hospitals, it's also within our home support services, having carers available to us, also within the private nursing homes. And just to say, that number that I mentioned does not capture private residential care, so all of the private nursing homes. It will impact on day services, where again we have to prioritise our 24/7 services in terms of having sufficient staff for people who are residential in units, our regulated services. And in terms of I suppose the rest of it then, having the impact within our hospitals, as I've mentioned, not being able to discharge people due to the lack of carers, and all of the problems that then causes in terms of backing up our system and impacting on patient flow. We also know that there's been a significant amount of activity for GPs who are central to our booster rollout and have been critical to the vaccination programme. They are also providing normal GP services, and we've seen significant issues there in terms of our GP out of hours in the month of December. So you can look at, again, not dissimilar to last year in terms of the volume of activity, but we are seeing very, very high levels of activity across the GP out of hours services. And again, that is putting pressure on them at a time where they are doing other things as well. And we certainly know that since they reopened from their GP out of hours services on Tuesday, they've been under significant pressure. So very high numbers there, 9,786. So, again, that will continue. We expect those high levels of activity to continue over the coming weeks. And we would ask people, as Paul said, in terms of just, understanding the busyness people can't get through, whether it's a GP service or any other service at the minute, by virtue of the level of activity and the level of staff absence. So this staff absence is impacting across the board. So everything we do. Just in terms of waiting lists, worth reflecting on where we got to by the end of the year. And again, kind of a good news story in many respects. So in terms of our inpatient and day case lists, we saw that number had been coming down from January of last year, impacted by the cyber attack in the summertime. It had reduced then in October down to 74,662, which was the lowest point it had been at all year, rose again in November, but had turned again in December to come back down. So we have been doing intensive work with sites in terms of that initiative to try and improve waiting lists, and we did see that come down. Where we saw very significant progress is in relation to our scopes and colonoscopies, which came down from 36,065 in January of last year down to 27,145. And that, you can see, is really the lowest point we had been at in terms of scopes since March of last year, so March of 2020, not 21. So a lot of work going on trying to address our waiting list, and in particular the longest waiters. So we've seen significant improvements in terms of the length of time people are waiting by targeting those who are waiting longest first. In terms of our outpatient waiting list, also a reduction down to 617,000, which is still a huge number, as you'd appreciate. And we have to remember that these waiting lists are ultimately people. So they're not just numbers, they are individuals who are waiting for appointments that many of us will know people who are currently on waiting lists. And it's very distressing when they hear about cancellations, etc. But we have made inroads there in terms of reducing that number down, and we will continue to do that. So that's a key focus for us this year in terms of continuing to tackle the waiting list across inpatient, day case, scopes, and outpatients. Just in terms of where we're at today, as Paul mentioned, 941 in terms of hospitalised cases today, up 52% on the same day last week. So it's interesting to look at that graph at how quickly it's gone up. Very significant climb in just a week. And we can see the confirmed admissions in the past 24 hours at 100. And we can see in the past 2 weeks just how that reflects. So again, quite a high number in the last 24 hours. Back, we had the same about a week ago. Just worth mentioning the outbreaks, because we continue to deal with outbreaks in terms of our services. So 369 open outbreaks in long-term residential care facilities. The reason I'm mentioning this is that we have outbreaks being managed in residential care. Those environments also have staffing challenges, and critically, we don't have staffing to be able to deploy elsewhere. So this is why the whole system is really important when we talk about the impact of this surge. We are seeing in the past week just 4 new outbreaks in terms of hospital outbreaks and 5 in residential care, but still a significant number of outbreaks there that are being managed. We're not seeing the same number of people in terms of people being admitted to hospital or to ICU from these outbreaks, but nonetheless, these facilities are also very challenged in terms of their staffing complements on a daily basis. We can see the National Ambulance Service continues to be very busy. Now, interestingly, the graph on the right-hand side there shows that they're within normal range for the week, but that is because this week, or the week up to Sunday any year, would be very busy. So they are continuing to be busy. And again, as I said earlier, down 260 staff today. Just a reminder that we have our injury units for people who have minor injuries, and by that we mean sprains, breaks, minor burns. And those injury units are places to go if you have, I suppose, a need for those type of services. So in terms of our emergency departments, they're very busy. People will be clinically triaged on the basis of their need. In all likelihood, you will be waiting longer in an emergency department for those types of injuries than you would be in an injury unit. So we're encouraging people to use all of the different pathways available. We said GP out of our services, notwithstanding that they're busy, they are a pathway. Local pharmacies, ambulance is really only in terms of a last resort for emergency cases, and then making use of the injury units. So just in terms of helping to reduce pressure on healthcare services, asking people to follow the COVID-19 guidance, getting vaccinated, a key message for everybody. Again, test and trace, flu vaccination. So we are still encouraging people in respect to flu vaccination. We've been, I'm going to say lucky, but we haven't experienced a surge in flu. We really hope we don't. But an important point is for people to get their flu vaccination and ultimately to try and stay well, if at all possible, this winter. Thank you very much.
Just go through some of the principal disease trajectory at the moment at this point in the surge in Omicron cases, and how it's translating through to harm and the increasing information we're getting from other healthcare systems as well as our own experience. So you see there that a huge increase in cases, a surge up to now a 14-day instance of 4,450. Just to put that in perspective, in the peak of January when we saw that huge third surge, it peaked at 1,492. The 5-day moving average, a huge increase. It's at 19,259. Again, compared to a 5-day moving average of almost 7,000 in January, and a big increase from last week of just over 11,000 cases per day. And looking at the total number of patients in hospital, that's where the disconnect begins, is that it's 941 versus almost 2,000 in January, but it's still an increase in the beginning of December. Likewise, ICU, just about half or less than of what we saw in that peak in January at 94. So that what we've seen is the parallel rise in cases along with hospitalisation, ICU. The congruence isn't there anymore, and that's certainly either a function of the protection the vaccine programme has given all of us, notwithstanding the waning effect, waning immunity against all types of infection, and perhaps also some features of the Omicron variant itself. So looking at the hospitalisations, cases at the top, sharp rise throughout December, in line with what we're seeing through other healthcare systems. This rapidly displacing Delta to be well over 90% of cases now. The middle graph shows again the hospitalizations, again less sharp rise, but hitting over 941, increasing from what we had in September at 311. And the ICU, because of that lag time, difficult to read yet, is what we're seeing, that flat number of ICU cases and other healthcare systems. We haven't yet seen the surge in ICU dependency that we fear always follows a surge in cases and hospitalization. So, but a phenomenal number of cases, and even if this variant proves to be less virulent and fewer cases translate through to hospitalization by sheer force of numbers alone, even a reduced number of cases translate through to harm, that will cause a tremendous impact on healthcare systems. As you've heard, including absenteeism due to either positivity in tests or close contact for healthcare workers. And we see that extraordinary figure, 25% of all cases in the past 12 months have occurred since Christmas Day 2021. Looking at the demographics, some health warnings associated with this graph in terms of the absolute up-to-date accuracy of all the figures, but we see that increase, if you look at the bottom table, increase in all age groups, but particularly a surge in those from 1924, 25-34, 35-44 age groups, big increases of 200%, 130 and 80% respectively. We are seeing some increase after a period of fall in older age groups, but from a very low base and not nearly as acute in terms of the steepness of the curve, suggesting that that benefit we're seeing from existing vaccination and of course from the booster program, which started off in older age groups. And that's the age specific instance showing that big rise. If you look at the 1924, 25, 34, 35, 40, big step in age group. There's the booster. Those dotted lines represent when the booster began in the over 80s on the left-hand side and the over 60s on the right-hand side, thereby conferring a protection on those older age groups, which although they've shown an increase in the past week or two, still going from very low base and not nearly as acute as we've seen in younger age groups. And the age profile of patients in ICU, what we've also seen recently is a shift to the left in terms of younger people in ICU. The over 50s for 68% of ICU patients and has fallen to 56% of ICU patients in January. So that's a left shift in terms of age for the age profile of patients in ICU. And the vaccination status in ICU, you've heard this referenced multiple times. Unvaccinated individuals continue to be the highest proportion of patients in ICU, even though they now comprise a small proportion of the eligible population, 5% or thereabouts. So fully vaccinated people, about 44%. Admissions to ICU, no vaccination, 51%. Ross will go into this in detail from his experience directly in Beaumont Hospital as a respiratory physician. And we see here that we've also looked at those patients requiring additional support outside ICU, and the figure is steadied in recent weeks at about 219, half of whom have COVID-19, the other half needing support for other respiratory conditions. WHO Omicron update, going through those different metrics, the way it measures its impact of transmissibility. Substantial evidence is a big growth advantage over Delta, doubling time 2 to 3 days. Increasing data from here, and it reflected also in the UK that there's perhaps less clinical severity and reduced risk of hospitalisation, but less as such too early to say that once hospitalised, what impact will it have on hospitalised people? Are there any at a reduced chance of admission to ICU? Effectiveness of vaccines, certainly some evidence of immune evasion, hence the booster vaccine programme, and also immune evasion from those who had prior infection. Again, just leading to what Ross says, there's some evidence again that the nature of this particular virus, it seems to colonise the upper airways more than the lower, and that may account, may be an early sign of its decreased virulence as a virus and perhaps explain some of its behaviour. Some data coming through from South Africa on hospitalised patients showing a reduced, compared to previous surges, if you look at those coloured bars representing each of the wave, a reduced proportion of patients requiring oxygen therapy, mechanical ventilation, admission to ICU, length of stay, and deaths. If this holds true in other countries, it's certainly a cause for hope. But certainly, as I said before, if the sheer numbers of cases we see, even if they convert at a much smaller degree to hospitalisation, and those who are hospitalised convert through at a smaller rate to ICU, we're still going to be dealing with big numbers, and we're already seeing that impact. Some booster vaccination, additional evidence is showing additional protection against symptomatic COVID-19 compared to those who are just relying on the second vaccine dose. And so when we look at this immunity story, again, Omicron attacking on the left-hand side of those red viruses, the two vaccines offers a first line of defence, particularly against severe illness. That's, despite the reigning immunity against all forms of infection, that protection from a completed vaccination course is good in terms of protecting against severe disease. The booster vaccines give a robust additional protection against all forms of infection and also additional protection against serious illness. And there's those other parts of your immune system we call T cells and memory B cells, which seem to linger around. And as the name suggests, in the case of memory cells, remember the immunity that you require once you get attacked, even if antibody levels have gone down and your other parts of your immune system appear to have waned. That we've looked into this boosters already and those high impact of the booster campaign, big uptake in long-term residential care facility of almost 100%. Healthcare workers approaching 80% or more of the eligible cohort. Over 90% of those over 70 and almost 80% of those who are medically vulnerable. And going through the age groups, we can see the uptake is now, in terms of the eligible population, is well over 50%. In total. Key messages, Omicron is highly transmissible with a degree of immune evasion from either prior infection or from vaccination, and evidence that it may cause less severe disease, but the huge numbers we're seeing are causing considerable strain in healthcare systems, both through patients presenting and also through the impact on staffing, not just here, but the NHS and other countries. And as such, healthcare systems remain under considerable pressure. That message we say again, and I know it's repetitive, but it's true, unvaccinated people have no protection from the virus. They don't have any protection either from acquiring the virus itself or from serious illness. So when we talk about this particular variant perhaps being less virulent or aggressive for unvaccinated people, they don't have any protection against either infection or against severe illness. Vaccinations alone don't control these huge case numbers we're seeing, hence the additional public health measures emphasising the reduced opportunity of transmission of the virus, whether it's through reducing contacts and mask wearing. These remain critical to controlling the case numbers. Vaccines remain absolutely hugely important against protecting against severe illness, including hospitalisation and death. And as we've said before, prevention of infection is much easier than treatment. So now I'd like to hand you over to Professor Ross Morgan from Beaumont Hospital, respiratory consultant, who might add to his experience, present you with his experience on dealing with COVID-19 in the hospital setting.
So thank you, Colin. So Ross Morgan is my name. I'm a respiratory physician in Beaumont Hospital, and myself and my colleagues there receive patients who come through the emergency department with respiratory illness associated with this condition. So I guess I'm in a position to be able to tell you a little bit about what's happening on the ground, so to speak, at least in my own institution. I would see it that there are three broad categories of patients. They split roughly along the vaccination and unvaccinated lines, as one would imagine. For people who are unvaccinated, the condition of COVID pneumonitis, which is where they get acute lung injury from this virus, which gets down to the lower airway passages and causes a very severe respiratory failure. Those patients look the same as the first patients I saw here in March and April of 2020. They have the same level of severity of lung injury, of oxygenation impairment. And unfortunately, many of them end up on high level of respiratory support and ultimately in the ICU. Thankfully, that number is fewer, as most of our population, as we've heard about, has been vaccinated. The other two categories of patients that we are seeing admitted at present are those who are vaccinated, perhaps not completely with regard to boostering. Some of them will have a shorter length of stay, thankfully, because the illness is less severe in vaccinated individuals. some of them have complications of the virus or potential complications of the virus. For example, blood clotting and blood clot conditions, pulmonary emboli. And those conditions are obviously an extra burden on diagnostic services. So for instance, CT scanners in the hospital and access to those. The second group of vaccinated patients are a very unfortunate group because they are vaccinated but have underlying medical conditions. Perhaps they are immunocompromised in some way. They might be immunocompromised because they're undergoing treatment for cancer or radiation treatment for cancer, or they're on medicines and medications to suppress their immune system because of an underlying condition that they have. They may also be medically vulnerable for other reasons, such as chronic lung disease or heart disease or kidney disease. And unfortunately, they're a large burden of patients in our population. And they're, I guess, unlucky in the main because the virus is circulating at such a high incidence, as we know, that they've been in contact with it. And while it has reduced the severity of illness for many, there are still large cohorts of those patients who unfortunately have acquired this virus. In the context of that, I suppose, in this chronic lung disease or chronic patients who have underlying conditions, we would normally see at this time of the year a large uptick in patients who present with decompensation, or what we call, I like to call lung attacks. I think everybody is familiar with a heart attack. It's a fairly common term we use, but the concept of a lung attack for people with chronic lung disease, for instance, chronic obstructive pulmonary disease, COPD or asthma, that can end them up in hospital at this time of the year, often virally induced. So those patients have COVID-19 associated exacerbations of their illnesses at present. And naturally, when they're in the hospital then, so this 1,000 or so patients, or a little under that at present, I think I heard the numbers today, those patients need to be managed in particular environments in the hospital that might reduce transmission to other vulnerable patients in the hospital and to staff indeed. Nobody in Ireland is hospitalised with mild anything. Why would you be hospitalised with mild anything? We spend a lot of time trying to work on ambulatory models of care and keeping people out of hospital. So if you're in hospital with this condition, you're sick. And most of the people in hospital with this condition are sick with this virus. Because of the level of incidence and circulation, there are patients in hospital that I see that are in for other reasons who happen to have COVID as perhaps a bystander, hopefully for some of them. But nonetheless, they remain a very large challenge. I guess to reflect on those three categories I mentioned, the unvaccinated patient, fewer than this time last year, fewer than March of 2020, the numbers are fewer. But for every patient in the ICU, we probably have two behind them in what we would call an orange zone of high oxygen requirement. Often these patients are very sick, feeling very breathless, are on high-end respiratory supports. We would call them CPAP and oxygen high flow devices. So there's probably, I think as Colin demonstrated in the slide there, for the patients who are in the ICU, there's probably it's a 2-to-1 in terms of the patients who are in this orange zone. We've learned a lot about how to manage unvaccinated COVID pneumonitis because we've been looking at it for 2 years. And so we try to avert ICU admissions, obviously, to save that resource, which is precious and limited. So these patients are managed in other areas of the hospital with appropriate respiratory intervention from nursing and multidisciplinary teams. And unfortunately, those patients end up, about 50% of them, we can avoid a transfer to the ICU for them. And then some of them who end up in the ICU, unfortunately, don't survive their illness. The other category of patients, as I mentioned, we're learning also how to manage them a little bit better. It is early enough in the most recent wave of this virus that we've become all very familiar with Omicron, that we're not certain whether all of the complications that arose in the first and second wave of this virus that led to blood clotting conditions being much higher and other, as we call it, extra or outside of the lung effects of this virus. We're not certain if that will be the same. Obviously, we have to be very cautious and watch that space. Many people have been exposed to this virus, obviously, in the community, and thankfully most are vaccinated, and so the condition seems to be mild. But with the volume of patients, I suppose that even that small number at this time of the year, when I say small number, it's not a small number, but that 1,000 patients or so in hospital at this time of the year is massively challenging for the services on the ground. I mentioned the chronic lung conditions because that's an area I know well. About 1 in 5 hospitalizations in this country to emergency departments pre-pandemic were for acute respiratory problems. You can add the burden of COVID to that currently, and you could see, and at this time of the year, that 30 to 40% of patients coming through the emergency department might have a respiratory complaint. It's the commonest reason to see your GP at this time of the year. It's a chronic. The commonest conditions in young adults are chronic respiratory ones. So we have a huge burden of underlying respiratory disease, and COVID is clearly an additional massive burden over this past couple of years, and continues to be in the acute hospital environment at present. Colin?
David, come back there now. David's come back in.
David, yeah. I'm happy, obviously, to take any questions on that. And perhaps David.
Take them out.
Yeah.
Thanks.
Okay, folks. As is my wont, I'll take 2 questions from everybody, and we'll go around a second time and take 2 more, and then 2 more, whatever suits you. I'm going to ask you just to tell us who you are and where you're from, so the listeners or viewers know who you are. So, Fergal, you were the first person with their hand up.
Fergal Bars, RTE News. Can I ask Dr. Colm Henry, and maybe Professor Morgan have a view on this too, is there any data from hospitalised cases here in ICU admissions, obviously, to show the degree to which Omicron is less fatal here? And what can you tell us the data shows at this point in time?
Well, the data, ask Ross to comment on this too. The data at the moment, based on our own experience and evolving evidence internationally, shows, if you go through the sequence of cases through to severe illness and death, it shows reduced hospitalisation per cases in South Africa, other countries. Whether this is due to the fact that the virus is not as aggressive as previous variants, or whether it's due to the long-standing immunity conferred on populations by vaccine, it's hard to know which is which, but certainly yes. Secondly, once people go into hospital, are they any less likely to go to ICU? There's some emerging evidence from South Africa that may be the case, but not definitive yet. And thirdly, regarding deaths, too early to say because we're not at that stage yet. So, Ross, you might want to answer or add to that.
Yeah, thanks, Fergal. I think it's the data is not quite mature enough yet in terms of this. I mean, we know this condition typically, if we look at previous waves or what we know about it over 2 years, is that by day 10 things start to get bad. Usually between day 7 to 12 is a sort of a wobbly period for a patient with COVID disease. And if they get COVID pneumonitis, which is the lung injury I mentioned, it usually happens at that point, and then they come into hospital. And then the hospitalization period is lengthy. So you will know that patients who go to the intensive care unit are often there for 2, 3, and 4 weeks and longer, 2, 3 months on some occasions. So I guess the fatality piece is we're not quite there yet. However, as Colm has alluded to, I think the signals on Omicron are somewhat better than the previous viruses with regard to the nature of the virus itself, what parts of the airway it affects, so less what we call trophism or less attraction than perhaps to the lower airway. And thankfully, vaccinations have certainly, it's hard to see the difference, but I would say, as I mentioned there, that unfortunately, the COVID pneumonia that I see and that I saw this morning is the same as it looked, unfortunately, last year, for those who are unfortunate enough to get it.
And for Dr. Henry, I mean, I'm aware of cases where a person you contracted COVID-19 before Christmas, was quite ill, didn't have to go to hospital, has recovered, maybe not feeling super, but has recovered, but is still testing positive on PCR. And and that's continuing. So, I mean, what do you say to people who are in that situation? Would you hear of many that they appear to have recovered? They probably aren't infectious, but they're still showing up as PCR positive. What are they to do with their lives? How do they go to work? They can't go into work, I guess. When do they know they've finished with COVID-19?
There's a couple of possibilities here. Again, I might ask Ross to come in as well. That the first possibility is that they have residual PCR from the original infection. The second is, if you look at, you asked for the time period before Christmas, Fergal, when the Delta was still a dominant variant. And what we do know with the Omicron, it appears to evade natural immunity, even from previous infection, and that would include Delta. So it is possible in some cases that you see reinfection, and we're seeing that more with this variant than the previous variants. But what is our practice, as I'm sure you know from previous questions before, is that where there's doubt, where there's a high CT value, is that sometimes the test is done 48 hours later to see if there's any increase or reduced CT value implying a more acute infection, or whether it still stays low, implying there's residual PCR. Do you want to add to that?
Yeah, I mean, this is the big conundrum. I think the difference between being infected and being infectious, and I think that's not dancing on the head of a pin at all. It's a huge issue. Generally speaking, we don't repeat PCR. People have variously described it. I think one of the best descriptions is, taking the fingerprints the day after the burglary. The burglar has left the building, so the PCR may be positive for some time. We do see and have a lot of patients who, for instance, in my own institution, I had a discussion with a colleague this morning about a patient who had a transplant who continues to be PCR positive. That might be a different scenario of continuing carriage, and they may be unwell with the virus. But for the vast majority of people, thankfully, we wouldn't be repeating the PCR, Fergal. It really, after 10 days, most people have recovered. And so the need to do that, perhaps necessary in some environments, but I would say for most people, it should not be a concern.
Hi, Louise Byrne from the Irish Daily Mail. Happy New Year to you all. Just to ask about the booster programme, I know the uptake has been exceptionally high, but has it slowed down in the last kind of week and a half? I know we were doing kind of 100,000 a day, if not more, before Christmas, and we 35,500 yesterday, and like 270,000 over the last week and a bit. Has that slowed down? And if it has, why would that be?
The straight answer, Louise, is it has, in terms of people coming forward and presenting for booster vaccination. There's a couple of dimensions to it. Certainly, prior to the Christmas period, we saw a massive uptake in those 4 days. We'd practically 400,000, 100,000 a day. Over the Christmas period, you can imagine, people had other things going on, and we are expecting, as people have settled back into routine and back into work for people. What we are seeing positively is the self-appointment process working, and people are booking appointments. And particularly positive about that are people are meeting the appointments. So we're not seeing the same drop-off we would have been seeing previously. But, however, we are making a call to everybody, come forward for your vaccination, come forward for your booster. It's really important. You've heard the medical evidence here today. And, we would have concern that people are dropping off. This is as important now as it was in the 4 days up to Christmas. And protection against Omicron, we know it's proven. So, yes, we'll be calling on the public, come forward. Certainly, you will see a slower levels of per week as we're getting through some of the 5 to 11-year-old kids, for example. And we'll be reappointing now people, the 100,000 who got their immunocompromised third vaccine will now be called forward in January for their booster. So you'll see a whole set of cohorts coming through differently. So, volumes may not be there, but I am sending out a real plea for the public. Please come forward. Please self-appoint your booking, or indeed, please go to your pharmacy and seek it as well.
Is there a part of that as well might be the number of cases that we've had in the last number of weeks? Is that a concern as well, that because so many people have been infected, they won't be able to get the booster now for a few months?
Yeah, I mean, the high levels of numbers that we've seen since December, since Christmas time, is a massive factor. It's a massive factor in the population, and also factor into that, not just the positive cases, you may have other people who are isolating. So, that's been a factor. But I would be still making the plea to people, come forward, make your appointment, and the centres are there, the GPs are there now, and pharmacies are there.
Hi, Niamh Griffin from the Irish Examiner. Happy New Year and happy Nollaig Naman. And so the the kids' vaccines, can I ask about the high-risk kids? I know Damien isn't here, but we've had a lot of families contacting us saying they registered on December 27th and now sort of not high-risk kids in their towns and villages are getting vaccinated ahead of them. How did that happen?
Yeah, just to give you the top line figures and then specifically in relation to the kids. So there's almost 70,000 of the 5 to 11-year-old kids in total registered now. Of that 70,000, just about 10,000 of those were kids who would have registered in that period, so high-risk kids who would have registered in the period 28th of December of the 10,000 kids. There's about 6,200, almost 6,500 5 to 11-year-old kids completed now in total. Of those high-risk kids, the 10,000 kids who are there to be done, there's, as of this morning, there are about 800 appointments still to go from. They've been working on that throughout today. It's much less now. And certainly most of those will all have appointments by this evening, at the latest tomorrow morning. There were some issues in terms of scheduling in a couple of centres in particular, where the scheduling moved ahead on all the 5 to 11-year-old kids instead of making the appointments for the higher risk kids. So we've addressed that. By the end of today, most of them should have received an appointment.
Okay, so you're pretty certain that that's being fixed now, because it wasn't really a couple of centres like just me and I'm sure other people here too. I talked to people from all counties all around Ireland.
Now, when I say a couple of centres, there were a couple of bigger centres with higher volumes where we've had to get the appointments walked through. It shouldn't have happened to the extent it did. It did happen. We've set out to address it. But when I mentioned a couple of centres, it was across a range of centres, but a couple in particular had high volumes.
Cayman Burke, The Journal. I'll keep the Nollaig Naman and Happy New Year greetings going. So we're hearing that people who have tested positive on antigen tests but weren't able to get a PCR and they're not able to register it on the HSE website. The website's only allowing them register negative results for some reason. Is there any way for them to register their COVID positive status, and will this be a problem with the new updated COVID certs?
So a couple of things on it. You are correct. You're correct in terms of the registration of a positive antigen works its way through as you're booking your positive PCR, as you're booking your PCR test. So if you're not able to book your PCR, it's an impact. We are looking at, our whole end-to-end system is built around the PCR process. That's from the time you get your GP referral right to the time to get your text after your result, etc. What we now have to do is build functionality around an antigen process. Our IT teams are working on that relentlessly at the minute, which ultimately is aimed towards registering a positive antigen test and some automation around that. So I can't give you a definitive date on that, but they're working relentlessly to have a facility to do that.
So is there any info yet on how the new certs will work, or is that even a HSE area?
Yeah, well, from our perspective, we're furnishing all of the data, and we are furnishing all the 2.2 odd million data to be processed. Ultimately, the Department of Health lead that process with the OGCIO, and as you've heard publicly communicated, that's expected to start issuing very shortly. So that process is ongoing.
There's also reports today of up to 150,000 unaccounted for COVID infections. How much of a problem would that be for Ireland's COVID response? Or would it be the case where, these people essentially, they do an antigen, they never get a PCR, they phase out their antigen, they isolate and all that, and essentially they just wash through? Or does that create problems, or is it something that we can just sort of get through?
I might ask Colin a second just to give a kind of medical perspective on it in terms of clinical perspective, but just specifically related to a figure of 150,000 or whatever. There's no doubt we haven't seen the total volume that we're seeing. There's much more than what we're seeing coming through in our daily published cases. Absolutely no doubt. When you see 60% positivity level in the community, you can make all the assumptions of what the volume is. I don't think there's a definitive figure, right? That's certainly some indications in terms of what the modelling might be, but it could be in a range. But certainly that 150,000 figure has been communicated. Colin, do you want to give any context?
There's no doubt just that we're not that there's under ascertainment, as we call it, of cases. The positivity rate at 60% for community referral is huge. And it may well be that for every case we're picking up, maybe one or possibly even two more cases out there that are either through the fact that people are not symptomatic or for any other reason are not being picked up. And this has happened to us before. And that's why the focus shifts when we get to this level on that mitigation, on the individual responses that people must make with or without tests. The test is never intended to be an end in itself. What it does is it triggers and provokes public health response in terms of isolation, contacts, and breaking the chain of transmission of disease. And hence the advice at this point in time is, with or without a test, if you have symptoms, self-isolate. Obviously get tested if you can, but continue to self-isolate until you're at least 48 hours after your symptoms are resolved. That focus on a population level is what will break down transmission, not the testing alone.
Sarah King, Virgin Media. Just kind of my question is similar to Cayman's, just in relation to the recording of antigen positives. So I know you mentioned earlier that 100,000 antigen tests were sent out to symptomatic people aged 4 to 49. So I suppose on the basis that we have about a 50% positivity rate, it might be safe to assume that you're looking at around 50,000 positive cases then. Is that fair to say, based on those being sent out? And is there going to come a point maybe where we start to share data where we're reporting confirmed PCRs and then also the number for antigens on a daily basis? Do you envisage us getting to that point? Obviously, they will not be validated, but just that we would have an understanding, I suppose, of how many positive antigens we're dealing with.
Yeah, I'll answer the first part of the question and qualify the second part. The first part is, as said to Cayman, we do want to, as soon as possible, have that functionality to record that antigen positive test. And our IT teams are working on it, and hopefully very soon we have a solution around that.
Are we talking like weeks or days, or what?
No, not weeks, certainly not weeks, but yeah, a lot shorter than that. A lot shorter than weeks.
Okay.
But that's what IT teams are working on. The second piece of it, in terms of the count of antigens, that's ultimately a judgment that NEFIT would make from a public health perspective, and we'll wait any direction in terms of that.
And I suppose then, just in relation to the COVID tracker app, I don't know if you've been on it yourself recently, but the information on it is totally out of date. Why is that?
It may be some relevance of the flow through the information into the GeoHive. I'm not certain, but that has been an issue in the past. Some aspects of it are certainly all up to date. I know the ICU, hospitalizations, COVID cases.
I suppose just if you look at the close contact information, it's saying you should restrict your movements for 14 days.
Oh, sorry, the health information.
Yeah, the health information. I suppose, which really, I suppose anybody who's in that situation might turn to the app for advice. So it is conflicting with what you're getting on the HC website.
Okay, well, what I would say, and just urge people, please do, just for health information, particularly for the moment, because there's been a number of changes, do go to hsc.ie, because it's not simple when you if you try to explain all the scenarios, it does sound complex. But if you go to the HSE site and you know the scenario you're dealing with, whether you're symptomatic or boosted or vaccinated, it actually is very simple definitions on the HSE site. But I will check in terms of the correlation back to the app. Thanks, Sarah.
Hi, just a second there now. Paul Cullen from the Irish Times. I felt there was a slide missing there, but just maybe for future ones, but if you could give some indication of the amount of work that is being cancelled as a result of the COVID crisis. I mean, on one reading of the slides that you give there are fewer trolleys than 2 years ago. There are 500 people in hospital who shouldn't be there when you're heavily stressed in terms of the demand for hospital beds. I mean, I know it's a difficult time. Every winter is a difficult time. But from the figures that your own figures you're giving there, and you did say that it was very different from last year, but you haven't quantified the amount of. Obviously, last year a lot of elective work fell away, but you haven't quantified the amount of elective work that's already fallen away here, by way of comparison. But on one reading, the health service is actually managing. It's got stress points, particularly in hospital beds, for example. But every winter is difficult. This one's just a different, difficult winter.
I think in terms of the activity, Paul, so a couple of points on that. One is, so when you're talking about the year, perhaps this time of year, we wouldn't be booking a lot anyway. And remember, when it comes to electives and scheduled work, it's not all about cancellations. It's more about the fact that we don't book it. So we're not cancelling lots of people. We're just not booking lots in sometimes. So it's a hard count. The other point that I didn't put up there would be the use of private hospitals. So a lot of that work that we're not doing in terms of our own sites over the year, again, if you look at it for the whole of 2021, and it's an exercise we could probably look at, in terms of the work that we have deployed out to private hospitals and the bed days used there, which is an indicator of the amount of activity that's transferring. I think it's, at the minute there are so many moving parts. So in terms of sites are managing, they're doing whatever they can at the minute. And you'll know this from previous years. This week, next week, there are always weeks where we're just trying to keep things going and not have huge numbers in our EDs, etc. The reality is, though, that the burden on our system, it is about that triangulation between the COVID numbers, the unscheduled care and the electives. And yes, we've been doing actually far more electives. I think, being honest, in December we did far more than we thought we would do. We thought we would do far less based on the pressures in November, but in fact sites managed to keep a significant amount of that activity going. So I guess there's all different types of stories we can tell, but the important piece is that we are down. The message for today is that we are still doing the unscheduled work, because that's we can't not do that. We have to care for the COVID patients, and we have to do the time-sensitive and urgent work. The rest of it, sites are kind of capturing that themselves. We don't necessarily capture all of that on a daily or a weekly basis centrally. What we do have is the amount of elective activity that's been done, so we can show that. But in terms of what we're not doing, it's a harder count, because it's...
We just go to Ross, given that living that at the moment, so maybe he might have a perspective.
Yeah, thanks, Paul. I completely agree. This is the time of the year for hospitals. I'm old enough to remember 2017, 2018, 20 years ago, whenever that was. There was about 5,000 admissions with flu that year. We had a really bad flu. A couple of hundred patients went into the ICU with influenza that year. So yes, this is the time of the year we get a lot of these extra pressures. In the first, I would say, just in terms of my experience in my own institution, that urgent cancer, time-sensitive care is continuing. The biggest challenge, I suppose, is with regard to staffing at present, because of the amount of people out either sick or close contact is the same as every other essential service that we have. And so that is a major challenge. When I look at, and we reviewed our, for example, data on cancer presentations with lung cancer to our hospital in 2020 in the first wave. And unfortunately, normally speaking, that condition, which is a common condition, common cancer, about 1 in 4 people present with an emergency presentation of that condition. Typically in a typical year, that rose to about 40% in late 2020, because people were deferring care and not getting their care, or delayed care, deferred care, and care, that sort of schedule type stuff wasn't done. I think on this go round, we're managing to maintain that just about, but there's phenomenal pressures on the staffing side of things, and the utilization of the private capacity is certainly helping that.
Sorry, just 2 brief points, and Morgan kind of catching at the end there. Anne touched on it. We were using, just prior to Christmas, about 17 or 1,800 bed days per week from the private health system. And the weekly analysis of that was about 85% of those bed days were being utilised for elective care, so on our waiting lists. So that's a capacity that we didn't have to the extent we have it now. That's important for us. And then just finally, just give you a scale on the staff impact, and I can give the exact figures at some stage, but my recollection, I think we got to about 6,700, maybe 7,000 last year in January through the impact of the wave that we were dealing with then. Whereas now, I mean, I gave a figure of 8,500, but as Anne said, it could be probably double that. There's the impact, and that is really hurting.
Can I just make a comment, I suppose, on the delayed discharges or delayed transfers of care that we talked about, that you mentioned there as well, Paul, that, we have come, so yes, we have just under 500. We've maintained that. Last year we had that down just over 200 because we had a huge amount of capacity. We'd cleared out a lot of capacity in our system a year ago. That number was much higher. So in previous winters, it was much higher. We're up to 600, over 700 a couple of years ago. And I think that is something that it's a bit like the trolleys, it's an indicator. So the important count there is not the actual number, which is relevant. The important count of the bed days lost. So we used to, I remember as I'm sure many do here, a time where people were in hospital for extremely long periods of time, awaiting funding, for example, for costly home support packages or specialist step-down care or whatever. That has changed a bit now in that people aren't waiting. So we have a lot of other types of capacity available. We still have people waiting. And at the minute, when you look at the categories where people are waiting the longest, it's residential care. So our nursing home sector, in terms of them being able to take admissions from acute hospitals, sometimes there's a delay there if they're in an outbreak situation. Equally, in terms of our home support, we've discussed here before the challenges in terms of securing carers. So it's not a funding issue, it's actually about access to carers. We are trying to use community capacity for people rather than have them sitting in acute hospital beds. But when you look at that at a national level, that's where those numbers come from, as well as a much smaller number awaiting specialist care somewhere. But again, the bed days lost since 2019 have more than halved. So we've made significant inroads on that.
Can I just ask Ross just two questions quickly? Firstly, are you able to tell whether patients in ICU have Omicron or Delta infections? You know that Taoiseach mentioned this recently. And the other thing was, would you have any insight into why your hospital manages consistently to have next to nobody on trolleys and also hospitals in your hospital group, whereas others are coming down with trolleys? Have you any insight into what your work processes are that maybe the rest of the system could learn from?
Yeah, thanks, Paul. Maybe just taking the first question. A lot of the patients in the ICU have been there for a period of time, I suppose, Paul, and so they're, perhaps came through with the Delta virus. There are patients going into the ICU now. I don't make a distinction, as I said, at that level, because once they're sick and they have lung injury, that's the issue at hand, rather than what type of virus they had, if you like. But that information should be available, all right. I can't give it to you exactly at the moment, but I can tell you that there's patients currently going into our ICU where Omicron is the dominant virus. The second question, I can't really speak to other places. I think there has been within our institution a lot of effort gone into trying to move patients through. In particular, with this over this past 2 years, there's been transformative practices, and I give the credit to colleagues and in other parts of the hospital on that. But we have a fairly well-developed system for trying to get people through the hospital. We do make, as I said, we make use of capacity off-site as well to enable that to happen. And we try to provide rapid access to ambulatory diagnostics and care.
I think it's very fair to say that in Beaumont it's quite a big hospital. There's also a lot of access to other capacities. So, there's, for example, Clontarf for Joseph Raheny and places like that. In other parts of the country, I think, Paul, in terms of places coming down with trolleys, there's an issue around bed capacity. When you look at the attendances, if you're to compare attendances around the country side by side, you'll have some, for example, Model 3 hospitals with very low bed capacity without other kind of egress pathways. So a lot of the big Model 4s have, in the east in particular, have good egress pathways. If you take somewhere like Galway, it's very limited. So Galway don't have Model 2 hospitals around. Here we have Mary's in the Park, we have Clontarf, we have all sorts of other places that people can step down into. If you're in Galway, you don't have any of that. So you have 2 private hospitals that are very busy, and you've Merlin Park, and that's just about it. So I think they're not all the same. They're not all the same in terms of their capacity or their different egress pathways.
Just a brief comment about your comments about the ICU and what the Taoiseach would have mentioned. The Taoiseach's comments were certainly based on feedback from ICU consultants around the country, just on exactly as Ross had said, they were dealing with long-term patients at that stage. The obvious qualifier on that is we haven't been through the full lag effect yet of all of the COVID patients coming through from Omicron. So, fingers crossed.
Any other come back? Louise, and then Niamh, and then Zara, and then Fergal.
Just when we were talking about the number of staff being out, do we have any figure for how many staff members have been given derogations over the last while?
I don't have it now.
We don't, and I think it's interesting, because what we're seeing is that a lot of sites aren't rushing to use derogations. They're using them where they really, really have to. And there's a whole risk assessment piece there in terms of the balance. For example, if your only choice is to close beds and you're really strapped for beds, then you don't want to do that. So there's not a huge uptake. Certain areas, what we're seeing, for example, services that are very challenged would be those types of services that would have a low number of staff with high volume activities. So, for example, labs, where we're reliant on a relatively small number of staff to do very high volume work that would impact, for example, across the GP world as well as within the hospitals, etc.
Then just secondly, just to come back to the underreporting, do we know when that might be worked out? Is it going to be when we can get the antigen test registered, or is there any possibility that we can step up our PCR? I know it has been stepped up, but is there any possibility that that can be stepped up further to kind of try and get a better handle on how many cases there are?
Sorry, the first part of the question, when what might be?
When the antigen tests can be registered online?
Okay, as I said earlier on, our IT teams are working on it. I would expect it soon, where we have the facility on a portal to register antigen tests, but I can't give you because we're working with our IT partners as well in terms of delivery schedule and the design of it. But it is a new portal. As I said to Zara earlier on, the issues around would they be counted or in the total count will be a public health measure decided by NEFIT and the CMO, and we'll work to that.
So we don't really know when we're going to get a proper handle on how many case numbers there are.
Well, I think we've a strong indication that they're probably much more than what we're actually seeing right now, as I've said and Colm have said right now. When you're dealing with 60% transmission levels in the community, you could be in any multiple of where we're right now.
Niamh.
Thank you, Niamh from the Examiner. And you were mentioning there about the home care, and you said a few weeks ago that there was almost 5,000 people waiting for home care. Do we know what that figure is now?
No, we're carrying out a validation exercise on that, Niamh, at the minute, in terms of just being really sure. We know that there are significant challenges now because of the whole absence piece impacting on a range of providers now in the home care space. But I don't have the current. I'll have that hopefully next week or the week after.
And just sorry, one more just for Ross. I'm just wondering about the people you mentioned, the category of unvaccinated people. What kind of age and sort of health conditions are those unvaccinated people usually?
Yeah, thanks, Niamh. They predominantly are younger, and so I would say they're up to 40s, 50s, and some of them are not, though. Some of them are. I've had a number of family groups, if you like, parents as well as children who are in their, say, 30s and 40s. But they would be predominantly from a younger age group. I think it's fair to say, Niamh, most of the older people and people who are frail with comorbidities have received their vaccinations.
Just David, if you look at our uptake figures population-wide, you'll see there's a gradual decline going down with age, high 90%, persisting over 90%, right down to the 40s, and then it begins to creep below, but it's remarkably high compared to other European countries.
Niamh, sorry, just back to your question earlier on the 5 to 11-year-olds. I was very anxious to give you the figures across the board, but obviously I'm extremely sorry that some of the vulnerable kids didn't get their appointment in the appropriate time they should have, because we are doing everything we possibly can to make this a good experience for our children, 5 to 11-year-olds, between the information that's on our site, the comic booklet, and I think, as you've probably seen reported, really good experiences as young kids are coming through with parents and guardians into the vaccination centres. So, it is unfortunate, and we're sorry that those children didn't get their appointments in the proper time. And as I said, we've, by the end of the day tomorrow, we should have that result.
I suppose to just bring you one question that I see coming up a couple of times today in the inbox, just people asking if they had COVID over Christmas and they had numerous positive antigen tests and they couldn't get a confirmatory PCR. How will they go about getting a recovery cert, or is it possible to even get one? And then alternatively, they're saying if not, then is it safe to get a booster after having COVID? They're concerned obviously because they're updating vaccine certs. So how should people go about this?
Do you want to take the booster, Pay?
With a vaccine, first of all, or the booster, first of all, if you're in the middle of your primary vaccination course and you get COVID, then you wait 4 weeks before completing the course. So if you've had the first dose, you get COVID, then you wait 4 weeks delay before the second. If you've had the primary vaccination course and you get what we call a breakthrough infection, you wait 3 months before the booster.
The issue for that person then would be that they actually wouldn't be able then to update their cert, or because from the 1st of February, you know, that the certs are obviously going to have a 9-month maximum on your vaccine. So this is somebody who had COVID over Christmas, but actually couldn't get a confirmatory PCR. So this person's not alone. I've actually seen a few messages like this coming in today. So that's going to probably be a bit of an issue, I suspect.
Yeah, and look, it is and all these things will have to be looked at from a public health policy perspective, but, you know, that is the current policy on it, unless it changes.
Okay, so just to be clear then, those people then are really in limbo then, in terms of actually having an up-to-date cert and even being able to travel now, despite the fact that they did have COVID over Christmas, they just couldn't get a confirmatory PCR. So just to be clear, those people actually have no answer right now, is that right?
And all of those issues will have to be and are being assessed by NEFIT, and we will take guidance on any change of policy on that.
Can I bring forward, if that's okay? I did indicate to him already that he'd be next, so in fairness, I'll come back and we've loads of time. We can come back.
Well, this is really for Australia, for my colleagues in Nuuk, for Dr. Colm Henry. Can I ask you just to outline what the impact of Omicron on the health system is at this point in time?
Well, if you láthar tá neart ólis ag hí maidir leis le iompar an víris seo agus maidir leis iompar an achraí seo agus tá an ionise sin ag dul ó neart ó cheacan go chéile agus do réir méid ólis tá ag ní teachtas an Africas agus an tíre eile fud na Eorpa is léiring dis na bhfuil si chu tromchúiseach mar galar agus sin ráte ag ghlacó leis líon na gasna agus tá ború mór fiú líon na gasna le seachtaí bag an nuas má hagan fiúháin níos lú casna as líon na casna sin béin na hospital fihrú agus béin na honid géar chum fihrú gan áras ach is cúis dóchas doing gan áras do réir an méid ionise tá agne nach bhfuil se chu tromchúsach mar galar.
Sorry, Cayman Burke from the Journal here. Just in follow-up to Zara's question there, let's say somebody really had to travel or wanted to travel or whatever, and they had their antigen that gave them a positive over Christmas and they've no confirmatory PCR. So there's nothing stopping them essentially just going and getting a booster now if they're eligible. Is there any kind of health impact that could be there? Now, so other states, for instance, the UK, it's only 4 weeks after infection. I know somewhere other places in Europe, it's as little as 10 days. So
just to reiterate, it's an important question you ask. It's important to give clarity in this. Is if you haven't completed your primary vaccination course, in other words, if you're still in the middle of it, and you get an infection, which happens because you don't get the complete protection until you've completed a vaccination course, then you delay the second dose by 4 weeks. If you have completed the primary vaccination course and you get we call a breakthrough infection, then your booster must be delayed for at least 3 months.
And what's the stops? I mean, let's say someone went and did it after 2 weeks because they wanted to travel. They've had their 2 doses. Then they had COVID at Christmas, but they couldn't get a confirmatory PCR. And now they want to go on holidays or they have to go somewhere. What's to stop them just going and getting their booster after 3 weeks or 2 weeks or?
Well, I'm talking about what the advice is, and that's the advice we give to people. And I would urge people to stick to that advice. There's a rationale behind it, and the rationale is that you have there's particularly strong evidence that those who are primary vaccination and get an infection have a particularly robust immune response against infection and particularly against serious illness. So it stands to reason in their personal interest that they wait for 3 months for the booster rather than have it immediately after their infection when it won't get the same protracted benefit from it. So I can't govern for how people behave after, as determined by other interests they have, but that's the medical advice we're giving.
Yeah, Paul, can you explain why the HSE appointed so many more senior managers in Q2 of last year than it did doctors and dentists? It added just 5 whole-time equivalent doctors and dentists according to the material you presented to the board during the year.
Okay, so there's at a quarterly stage we present the various, actually at a monthly stage we present the census recruitment data, Paul, and I don't have all the figures to now, but roughly about 11,500 people recruited from January 2020 to December of 2021. The breakdown of that is actually fairly balanced. There's about 3,000 nursing and midwives. I'm working off the top of my head here now. And on actual consultants, it was 265 for the end of last year. And across the board, medical and dental, and indeed on health and social care professionals, I think there was about 2,800. So there was actually a very good stream across all medical, professional and healthcare assistants, staff and nursing. Certainly we had at a point in time of this year, earlier in the year, to recruit significant resources in terms of management of a very significant vaccination programme and a very significant testing and tracing programme, both of which organisations didn't exist a year and a half ago. So we had to put a structure in around that. But equally, I would say a lot of the management and administration positions across the system are in actual support of the health services, both in community perspective and also in the hospital system. So I think if you look at the full census from December of 2021, you'll see a fairly balanced actually breakdown across nursing, midwives, medical, health and social care professionals, patient and client care grades.
And I think worth noting that some of those grades as well, Paul, are people. So, for example, as Paul said, you've got the vaccination testing, but equally you have disability services, mental health services. They've all grown, disability networks, children's disability networks, etc. So they're counted as management grades, but their team leads in networks, etc. So they're not, there's a kind of a perception that they're people sitting in office pushing paper and somewhere they're not. They're people actually out working with teams. And certainly the feedback when we go out to clinicians about staffing, one of their biggest issues is that where those people don't exist and we have clinical hands-on people having to do those jobs, it doesn't work either. So these people are really critical to the running of our service as we roll out all of the different structures around enhanced community care, children's disability networks, our mental health, different types of services and responses. So I think it's important that people understand the management and admin bit is a bit misleading. There are actually many of those posts, as Paul said, are very service-based.
I hear what you're saying. I suppose the question could be why so few doctors, presume they're mostly doctors, not dentists, why you just added 5 whole-time equivalents in a 3-month period.
But between doctors, there's a phasing period in which doctors are, yeah, I'd have to look through the detail of that 5, but if you take consultants, Paul, it's 261 of the year, there's not, that's been probably the biggest number of consultants that we've hired since a long period of time. In fact, across the health services professionals, that's been the biggest number.
Hi, sorry, I know I'm going on about this now, but Colm, do you reckon the people then who had COVID over Christmas who couldn't get a confirmatory PCR might be asked to maybe do an antibody blood test perhaps to get a cert, a recovery cert, or should they be should they be asked to hold on to the cassette with the confirmed antigen test as proof of having COVID? Would you be advising them, I know it might be a bit gross, but to store them safely, No,
well, look, as mentioned earlier, we're looking at anyone who's left behind in this. I don't have a direct answer for them now. I give them medical advice with regard to vaccine, which is very definitive as regards them holding evidence. The antigen test is certainly some evidence. Unfortunately, the PCR test is what links everybody through, whether it's through return to work or whether it's for surveillance purposes. But that's been addressed now. I don't have a direct answer for them now.
Final question, just for yourself, Anne. I know that the day when we were chatting, was it Tuesday, you were saying there was around 230 beds had to be closed because there just wasn't staff there to open them. What's that number for today?
It's still about that. So between the closed and blocked beds, we've just over 400, and about 230 of those are closed beds by virtue of staffing or infection prevention control, but predominantly staffing. And we have today about 122 beds, I think, in our system. So actually, that's an important number in terms of available beds. It tells us how full the system is. Now, that's taking into account the closed beds as well, so not a whole lot available nationally.
Okay, folks, I think you've run out of questions. Okay, so thank you very much, everybody. We'll see you next week. Thank you.
Thank you.